Good afternoon, Ashish Babulkar. I just came in through, so kind of finding my feet in here. We have a fantastic panel and we hope to stir everybody up because this is a post-lunch session, so we shall not let anybody sleep. So we should have more controversy. Let's start with, you all know the panel. The first item is scapular dyskinesia. So let's start with Vivek. And in terms of your practice, what is the impact of scapular dyskinesia in the patients that you see? Now we are generally going to be talking about the non-operative patients who come with shoulder pain. So how do you approach the patients?
I think for me, scapular dyskinesia becomes very important. One, if I do not find, like when you start your examination, the patient will of course come to you with some kind of pain, stiffness, or alone pain. You start your history, you finish your history, you do the examination, you find this scapular dyskinesia at the back. Now for me, it is important to understand, is it the only problem in this patient? Is it the primary scapular dyskinesia causing the secondary impingement features in the shoulder, or is it the shoulder which is having a problem led to the scapular muscle imbalance?
Primary or secondary? Perfect. That's a fantastic way to start this discussion.
Yeah. And if I do not find any other pathology clinically or maybe by other investigation in the shoulder, then I would focus completely on the scapular dyskinesia, restore the muscle balance.
Perfect. I think, Vivek, you hit the right chord, because now you need to go down the path to see whether this is primary or secondary, and then, by hit and miss, you rule out. Sergio, how would you rule out secondary scapular dyskinesia?
Well, I strictly agree with Vivek, because I feel that scapular dyskinesia is a very important feature, especially in younger patients. And not only when you are thinking about rotator cuff pain or cuff pain or even impingement, secondary or as a consequence of scapular dyskinesia. And this is something that I've seen in the office and that gains my attention. But even in treating something that I don't know how frequent it is in India, but in my office it's a mess. That is myofascial pain over the superior trapezius. And I have a lot. Many people working in the office all day. So in these patients, especially when they have a lot of pain in the superior trapezius, they have a lot of scapular asymmetry, and I think that the scapular balance, the shoulder girdle balance should be addressed. Obviously, strictly non-operatively. In these patients, it's very important. And even in young patients, when I see that scapular dyskinesia has a relation with the impingement, and there's one test that I use a lot that is called the Kibler test.
Kibler test,
from Ben Kibler.
Ben Kibler,
So I put my thumb in the inferior angle and the point of my index finger in the supromedial border, and then with the other hand, supposing I am examining the right side, I stabilize the chest, and then I make like this, and if the patient says, "Oh, now I'm lifting much more easier," so this is a very nice way to diagnose and to confirm scapular dyskinesia.
That's a very good pointer, because what Sergio is trying to do is trying to anchor the scapula to the thorax, which the scapulothoracic muscles have failed to do. And that's why
my hand was doing
exactly
in the test was what the muscles should be doing, and they are not doing because they are weak or even because they are not working.
That's right. That's right. So that kind of tells you that the problem lies on the scapulothoracic side rather than glenohumeral side. Impingement is cleared and it moves through. Kapil, what's the target population in your neck of the woods with this kind of, medial scapular pain, trapezitis? Which is the high risk population?
I get worried when I'm sent a 27-year-old with shoulder pain, diagnosed as impingement by the rheumatologist, and given 3 injections. And it is not an uncommon scenario, and I see these 20. And that is what worries me. And when you ask them, the history is so atypical. Their pain is diffuse. I think the patient with classical impingement or cuff pathology will come and tell you my pain is here. Or with the AC joint, they will tell you the pain is here. But when they say my whole shoulder hurt and I get pain here, that is really worrisome.
Right.
That is that age group, sort of below 40, 45, women, office workers, as you said, and those are the weekend badminton players. These are the ones which worry. And when you examine them from the back, the scapula is just doing everything, and it's very nice. It's very what Steve Copeland taught me was always stand the back and examine the shoulder. Look at the level of the shoulder. Look at what the shoulder is doing, and look at the mirror. And that is what tells you that there is an asymmetry there. And that is what completely sort of sends this warning signal that this is not what it is. And the other problem is when I can't fit it into boxes. For me, under the age 35, think of instability. 40 to 55, 60, think of impingement. And I can't fit them into a box because the symptoms are very different. Then I worry about this capital.
So, any diagnostic tests to confirm that you're on the right track?
I think the examination and the altered scapular rhythm is the most.
Altered scapular.
Yes.
Can you give us a definition of a normal scapulothoracic rhythm for them to know it's normal? And
I think the key thing there is the asymmetry between two.
absolutely.
And that is if you've got an asymptomatic shoulder,
Yeah.
that is normal for that patient.
Yeah.
And you look at the anatomy books and that tell you that the scapula moves at 90 degrees or whatever. No, scapula moves whole throughout the abduction. And when you see an asymmetry between the two sides, that is what it is. Whether that inferior angle is moving, whether the middle border is prominent, or whether the whole scapula is moving completely, and that is what
They will have different grades, depending on what timeline that patient comes to us. But anything that is symmetrical and smooth is considered as a normal scapulothoracic rhythm. Anything that is not smooth and asymmetrical, so it could look wobbly on both sides, but as long as it's smooth and symmetrical, it's still a normal scapulothoracic rhythm. Shekhar, can you give us conditions that can cause secondary scapular dyskinesia, which would mandate an intervention or may not yield to a rehab program?
That can be secondary to impingement also. Mostly what we see in our practice is ladies in the age group of 35 to 45.
Yeah, those are the ones that are the primary scapulothoracic posture ones. Yeah. Yeah.
But I think
Any other high risk? Yeah, Sergio.
Yeah, there is a situation, it's quite uncommon, but I have operated 2 cases of elastofibroma or fibroelastoma in the inferior angle of the scapula, and I have even a video of a patient doing like this, and the scapula was climbing over the elastofibroma,
Right.
and then she was having a lot of cuff pain due to
Secondary to the
secondary to
dyskinesia.
Dyskinesia, and I just removed the
Yeah.
tumor, and it was 16 centimeters
Ah.
8,
Right.
and I did nothing to her shoulder.
That's right.
And
That's
she was
right.
okay.
Yeah. Yeah. I mean, similarly, you can have a scapular osteochondroma, which is typical, a long thoracic nerve palsy, which will cause serratus anterior weakness, and we've had tuberculosis of the, anterior to the scapula with a big abscess, which is throwing the scapula out of gear, and because of the stretch, the scapulothoracic muscles didn't work. So all these were primary conditions that cause secondary scapular dyskinesia, in which case you're going to treat the pathology as surgery did, ignore the rest, and they will all restore back to normal. But if that scapular dyskinesia has been there for a very, very long time, then you will have to add a rehab to them, because the rhythm goes, the proprioception goes, and the muscles fatigue so badly because these are postural muscles.
Yeah, just one comment. If you wait 1 year for the nerve to recover, okay. But what about if in a post-traumatic scenario, the patient is already 2 or 3 years and the scapula is winging, and then you make a nerve conduction study, well done by a nice guy, and you see that the nerve is gone, that would be an indication for a scapulodesis.
Absolutely. Yeah.
And I have done one in my life with good results, but the only message is these things exist. They are pretty
absolutely.
uncommon,
Yeah.
but they exist.
Yeah. There's another condition called as FSH, facioscapulohumeral dystrophy, but there's nothing you can do. You can do tons of rehab, you can spend years on the patient, it's not going to work, and in which case, it's probably the only genuine indication for doing a scapulothoracic fusion, because that helps these patients. Kapil, you're saying something?
No, I was about to speak about the dystrophy chief. So, and the other nerve problem that you have to think about is the accessory nerve, the trapezius muscle,
Yeah,
because
yeah.
that will give you scapular dyskinesia as well. And especially if somebody has had neck surgery or neck dissection.
100% iatrogenic after a lymph node dissection. We've not had a primary accessory nerve palsy. And there's been a nice test from Reading on the triangular sign published in the JSES. So we'll come to that. I'm sure do you want to allude to that?
Well, there's a few things. I mean, one of them is this. I wanted just to mention that if a patient comes with a small scar in the neck,
Yeah, yeah.
and you ask the patient, say, it's nothing, they just took a lymph node,
Yeah.
but there's got winging of the scapula.
Yeah.
You know that they
Absolutely.
severed the
Cervical access.
Yeah, unfortunately,
And this is very, very, very common.
it is very common. We see this very often.
It's missing
ENT surgeon, general surgeon. The funny thing is the dyskinesia doesn't start overnight. It's usually between 4 to 6 weeks after the lymph node's taken up. So sometimes the patient doesn't correlate directly to the surgery.
Wow.
So he just thinks it's his part of his recuperation. And in our situation, half the biopsies have come out normal. They were not indicated. So it's even more miserable for the patient.
Yeah. And then if they come like that, first thing to do is to try to reconstruct the nerve. If it's early, it may work.
Yeah, we,
May work.
Yeah.
If it's done early.
Heart surgery. Heart surgery.
Yeah, you
Heart?
have to reconstruct the nerve.
yeah.
If it doesn't work, then you can do muscle transfers, the Eden Lange procedure.
Yeah, but the muscle
Which
transfer is
works as well.
not as effective as the primary nerve transfer. So
Yeah.
we've had gaps in the axis nerve filled with sural nerve transfers as a cable graft, and within 6 to 9 months they have picked up
Recovered.
back to normal.
Yeah.
So we've done around 11 cases now on axis nerve, of which 9 were decompression, repair, adhesiolysis, and 2 with sural nerve grafts with a cable graft, provided the gap is not more than 1 inch, and we've had good results at 9 months.
I had one patient that came after 2 years, and I referred her to Stanmore, to the
Yeah.
our unit.
Yeah.
And they've done a graft, and she
Yeah.
recovered very nicely. On the other hand, I had a few other cases that they tried to do a graft, didn't work, and eventually I had to do a Eden Lange
Yeah. So-
transfer, and which worked very well.
Yeah, my suggestion is do the graft. If it fails, you can always go back to the muscle transfer, because it's a less morbid operation, the nerve graft. And even if it fails, it doesn't matter. It just leaves a small asensate part on the leg. And then you can resort to the muscle transfer after that.
One more thing about the FSH and the trochoscapular fusion. I think we have the largest series in the literature, and one of the biggest series in the world, probably in Reading, because we were the center for the whole country. And this is different. It's not dyskinesia. It's real winging of the scapula. And this happens because the only muscle that still functions is the deltoid. All the other
Yeah, that's
muscles
right.
are affected.
That's right.
And because the deltoid it's easier for the deltoid to wing the scapula rather than to lift the arm up. They've got this winging, and for them, trochoscapular fusion is the best
Yeah.
option.
But I'm sorry, you're talking about the facioscapulohumeral syndrome?
Yeah.
Yeah, facioscapulohumeral.
Dystrophy, yeah.
Okay, yeah. I have.
But that's a different story. It's different
Yeah.
from dyskinesia.
But from these patients, they benefit a lot with scapulodesis, yeah?
Yeah.
They
We have
benefit a
very
lot.
large series on that. We
Yeah.
have very long-term follow-up, over 40 years.
Right, let's move to the next topic. We've got 4 topics to cover, so moving on to undisplaced great tuberosity fracture.
We published 35
35?
in the last few years, but we have no longer.
Shekhar, there's a patient, young guy, undisplaced great tuberosity fracture. He's just come in fresh to you, 1 day history. How do you proceed, right, from which X-ray do you prefer? What's your approach? What do you talk to the patient?
Yeah. Because sometimes these fractures may look like undisplaced on one view, but actually it might be displaced. So it's better to take AP and axial view, and if it's undisplaced, the gap is less than 5 millimeter, then I usually just keep them in a sling and ask them to come again after a week and repeat the X-rays. if there are any signs that it's getting displaced, then we tell them that it might get displaced,
Yeah.
and then we'll have to.
Because there's a motor attached to it, so there's a chance that it can get displaced, and it's very tricky to identify the fracture line. How long would you immobilize them?
If it's not getting displaced for 3 to 4 weeks, then we start mobilizing.
Right away. And formal physio?
Formal physio after 3 to 4 weeks.
Okay. Yes.
What is the preferred method of immobilization of these
Yeah.
fractures? Is it a abduction pillow or a normal routine?
Routine sling.
I-
Panel, it's open to the panel.
I mobilize them in a normal sling.
Normal sling, yeah.
And
Yeah.
just repeat the x-rays after a week.
Yeah.
If it's getting displaced, then it's.
Yeah. Panel agrees?
I think the crucial bit is the X is in two planes.
Yeah.
Because then we have to remember that the tuberosity just never goes up the way, it goes posteriorly.
Posteriorly, yeah.
And, you know, I've seen patients where they come at a week and an inexperienced registrar sees them, he sees about 5 millimeters posterior displacement, reads them, and then by the time you see it's 4 weeks and it has displaced.
Yeah.
Every subsequent one takes an X-ray and 5 weeks,
Yeah.
5 minutes. So then the key is that the moment you start seeing it moving, you need to, and the other thing is, why has this young person got a greater tuberosity fracture? Is it after a dislocation? That it was so you need to have a very low
Yeah,
threshold of
yeah.
fixing it.
I would
Yes.
like to make two comments. I deal a lot with this in my public hospital. So first comment, when you have a GT fracture, you must be following these patients, at least in my opinion, week by week until the 4th week.
Absolutely.
Because I have already had in the last 6 years, 2 or 3 cases that in the 3rd week, unexpectedly,
They started displacing.
because of the pull of the
Yeah.
posterior superior cuff, it had a huge displacement. And I had even a case, January 2012, this year, that in the 4th week, oh my God, this is displaced, and I had to operate. And another thing is that it doesn't matter if you fix or if you treat conservatively a GT fracture, be aware of stiffness,
Yeah,
of
absolutely.
frozen shoulder. Because these particular fractures, they love to go to stiffness a lot, really a lot. I would say that the most probable frozen shoulder after a fracture, regardless of operating or not, is isolated
tuberosity,
GT
yeah,
fracture.
yeah. They give a lot of hassle because I think they are much more difficult to handle than proximal humerus fractures which are undisplaced, because there you can restore the movement reasonably sure that it will come through, but GT fractures can behave in a more erratic way. Vivek, is there a chance that there must be an associated rotator cuff injury along with the great tuberosity fracture depending on age, population?
I think in my experience and as well as the literature, there are the full thickness tears associated with the undisplaced or displaced GT fractures are not common. Full thickness. There may be some articular surface tear, and there is a tear, special tear described. It runs between the supraspinatus and subscap. There is a small tear which extends, and some of them whom I have operated, I have never found a full thickness tear. I think one of the key message is most of the time the GT fractures are undiagnosed, especially the undisplaced ones. People just miss it because the X-ray looks many times completely normal. They may be impacted on, and that's where I think we need to do a good sonologist, as you, your wife or someone, can pick up a fracture. Or best is to do an MRI.
Yeah.
And as they said, you have to do a repeated X-rays every week.
Yeah. So any hesitation and you're in doubt or something is inexplicable, when the stiffness is disproportionate to the X-ray, go get a CT scan done and you'll be surprised to see the injuries
But
there.
Just a comment.
Yeah.
We're talking about the simultaneous occurrence of a tear with a GT fracture. Well, I don't believe in this. Why?
What in 70, we're not talking about in this situation, a 70-year-old who's had an injury, X-ray looks okay. X-ray looks a small, that's why I said irrespective of the age. The point I'm trying to bring in here is maybe a 70-year-old GT looks just small crack, undisplaced, very nice, and then
In an old lady.
elderly lady, yeah.
She has the clinics,
Yeah.
search for a cuff
And
tear.
search for the cuff tear, that's very important. Because what happens is the pain and the dysfunction of GT masks the cuff tear or the subscap tear. So we've had couple, if we get time, then I might show you tomorrow where we've had lesser tuberosity fractures which didn't show up. The great tuberosity was undisplaced and we're very happily proceeding to treat them in that manner.
It has slightly different message, sir. The GT fractures are more common in general in a younger population, 20.
Yeah, they're usually younger ones, yeah.
In the older patients, those who have an undisplaced GT fracture, I believe that it's not the fracture which has caused the tear. The tear was already existing.
Possible,
in the population.
possible.
And then it became, the anterior most supraspinatus tendon.
They just
It was-
decompensate after that,
It
yeah.
just
Yeah,
decompensates.
absolutely.
So I think the message is
Yeah.
in those patients, you must get an
Yeah.
ultrasound.
Whenever you see that the history and the signs don't match up and the function doesn't match up, then that's the worry. Let's move on to grade 3 AC joint dislocation. Yeah,
Displaced GT fracture presents late, say after 4 to 6 weeks.
right. The remit given to me by the organizer was undisplaced GT. That's why I was trying not to get in there because we'll be here all evening. But let's see, if we get 5 minutes and we'll come back to your topic. And the message to you was just arm's length pouch, no abduction braces, they don't work.
Can we ask the panel what is their preferred method of fixation of a displaced?
Okay, a displaced GT fracture. Just a quick one-line answer, your choice.
Okay, transosseous sutures, and if I can give one message, and this is written, regardless of the technique you use, do transosseous sutures and be aware of impingement with screws.
Yeah. Okay, Kapil?
Treated as a cuff tear, we use anchors
Yeah,
with
yeah.
a suture bridge.
Yeah,
with
technique.
elastic arm.
Yeah.
The only message I can give is please don't put 2 screws into it, they shatter and then move.
Hmm. Yeah. Shekhar?
Open reduction and DVW.
Yeah. Vivek?
I think large fragment IU always single screw.
Yeah.
Single screw,
Hmm.
4 mm cannulated directly towards the neck of the humerus.
Hmm.
And if it is a smaller fragment comminuted, then I'll do the double root.
Meaning open, arthroscopic,
No, always open.
always open, yeah.
So when
Makes
you put
sense.
the anchor, I presume you put it arthroscopically.
He said,
No, it
huh?
can be done by
Either or.
Hello.
Either or,
In the
depends.
fracture bed,
It has to go in the bed.
Two anchors
Yeah.
in the fracture bed, medial row, suture bridge, then lateral row.
If you're doing an anchor fixation of a great tuberous fracture, and I think it's easier done mini open, some of us do it arthroscopic just for the fanciness of the procedure. You must always do double row. There is no doubt about it. A single row is just going to lift up the fragment just like that. So number one, medial row anchor 1 or 2, put the bites through the tissue rather than the fragment and get them over and put a lateral anchor there. That will plaster it down nicely and weld it in place. So you can't get away with one anchor for a GT fixation as such. So you must have a double row.
Has to be double.
Yeah.
Okay, but I would be afraid of doing a GT fracture retroscopically because I would have a lot of fear of the anchor pulling out because all that metaphyseal bone is cracked. So
But
I
Sergio,
don't
but the
think
anchor is going in mini open anyway.
Huh?
The anchor goes in a mini open also.
He
Yeah.
says that he wants to do transosseous.
Yeah, I mean the suture works beautifully with the new, yes, yes, yeah, yeah,
And
yeah,
it's easy
yeah.
and absolutely reliable.
Yeah, absolutely. So what happens is most of the time it's just a flake of bone. You put in a screw and it's just going to come into multiple. So it's like a wafer. If you have a nice chunk and 30-year-old guy and you want to do it percute, then don't do it percute. Open up, see it first and do it because the imaging is so funny that you will end up thinking that this has gone in very nicely and then 2 weeks later you see the x-ray once the arm is abducted in action, the screw is separate, the fragment is separate. So don't do it percute. These are not for percutaneous fixation. Must go in open.
The message is 2 things should be completely condemned. One is some kind of percutaneous K-wire fixation.
Oh yes,
Patient needs
100%.
And second
Yeah.
is even any kind of K-wire fixation.
Yeah.
It just doesn't
Yeah,
work.
it doesn't, it doesn't.
K-wires, yeah.
Yeah.
You would find people coming out with
Yes,
K-wires
yes, yes,
sitting
yes.
out, done percutaneously. And as you said, it's very funny.
Yeah.
You can't really know that whether you have fixed it or not.
Let's digress a little. How much time do you have?
you still have about 20 minutes.
20 minutes, yeah, we're doing good then. Nice bouncer to the panelists. I can't resist this. But patient has come in, he's had a GT fracture, it's gone malunited. You can see it proximal migrated, it's healed. It's healed, malunited.
Okay.
Greater tuberous in the wrong position. And he's impinging.
Yes.
How do you approach it?
I even have a presentation of this case in Humeri and in YouTube because I deal a lot with these cases and they come very late
Yeah.
to me, unfortunately. I treat it exactly as a fresh case. I do the same approach. I remove all the fiber optic tissue, and the only thing is this that I always tell my residents: in a chronic case and even in a fresh case, in a young guy, don't manipulate GT by the bony piece. This is gonna
Crush it.
explode
Yeah.
in your hand. So I make a long whip stitch with 2 or 3 number 5 anti-bond sutures. And sometimes in the chronic cases, you have to remove some part of the bony bed or of the bony piece to have a nice fixation.
But if it's united and you can't find the fracture plane, if you cannot find the fracture plane to do an osteoclasis,
I always find it using osteotomy under C-arm control.
right?
I do the C-arm and a good tip. As the head is retroverted, I have to put the arm with the elbow 90 and in external rotation. And then the head will be antiverted. So I will be seeing a true lateral view
yeah.
of the head. And then under that view, I can see let's say, the path to do the osteotomy, and I do the osteotomy slowly under C-arm control.
That's a very important point, and that's why I always do them in the beach chair, because then your positioning of the C-arm is going to be perfect to find the fracture line.
Sure.
The reason I brought this about is do not advise acromoplasty for these patients, because the problem is not on the acromial side, and you can see that the cuff and the GT are merged nicely in the wrong position. So the problem is not with the acromion, and that's not going to help this patient as such. Right, let's move on to, we've got 2 more topics to cover. Grade 3 AC joint dislocations. Vivek, when do you not operate and when do you operate? There's no escape. You got to take a side. Don't sit on the fence and tell me.
Agree with me. That's why it started really easy.
No. Don't be diplomatic here.
I think it's hard for me to answer, but I'll say in the older people, like anyone who's beyond 50, 55, who's sedentary habit, especially in our country, I would always rehab them. In 3-4 weeks time, their pain disappears. They start getting the range of motion. Gradually, they still come back. But I always tell them that you'll have this jetting out.
Yeah.
This will never subside. If you're ready for this, accepting, no problem. Their movement comes back, their strength comes back by 3 months. If they want this to go, then I do like in chronic ACG. But younger people, I don't advise them anymore.
So you think there is not much of an indication for an acute grade 3 AC joint fixation?
In the elderly people. But in
Young guy,
younger guys,
30 years, he's not too much in pain, but he doesn't like the deformity.
no, I would do.
You would do it? Yeah, all of this.
I'll always do it electively after 1 or 2 weeks.
Yeah, so you must wait for 2 to 3 weeks?
Yeah, about 2 weeks I'll wait.
Okay.
Just for the pain and inflammation edema to subside.
Sergio?
I will definitely not sit on the fence. 100% non-operative. I never operate a type 3.
Yeah.
And I have even doing conservative management in boxers, in people who make boxing. They have all come back. The only thing is the residual cosmetic issue. But basically 100% of these patients are men. It's very uncommon
I agree.
to see women. So women would have more
Cosmetic issues,
problems.
yeah.
So men, they say, oh, I'm gonna say that. So this is nothing. I never operate,
Yeah.
and I never had a bad result.
Yeah, I agree, Sergio, because the AC joint dislocation does not cause any major restriction in function of the shoulder per se.
On a
But
type 3.
but on a type 3, we are still on. We're going to stick to type 3. Hang on, Vivek, I'm not done. Right, okay, sure. So what we are clear here is a Rockwood classification, 6 types, and the type 3 is a superior dislocation with no contact between the acromion and the clavicle, both the conoid trapezoid gone. Sergio, you've got,
Do it at about 2 weeks. We just do the stress.
one sec Vivek, one sec. You have Vivek as a patient, he has a type 3 dislocation.
Yes.
He has no pain, he's not worried, he is not worried about a cosmesis, but he comes up at 4 weeks, you've conserved him, and he's a shoulder surgeon, he comes with medial scapular pain.
With
Medial scapular pain
4 weeks,
at 4 weeks.
I wouldn't worry so much. No, I wouldn't worry so much, because the main difference between a type 5 and a type 3 is the rupture of the
Trapezius and the deltoid.
fascia,
Yeah.
the trapezius
Yeah,
fascia.
yeah.
So the problem is that in a type 5, the body may have difficulty to pass load from the
That's right,
appendicular
yeah.
skeleton to the axial
Axial.
skeleton. But when the fascia is okay,
Okay.
it means that type
Yeah.
3,
Three.
this problem will not happen.
Hmm.
So I think that it's basically impossible to see long-term complications in type 3s. In type 5 is different.
Yeah. Kapil?
Type 3 default position is non-operative, counsel the patient. But there are, as Sergio said, there are young men, some of them really want to quick return to function. They don't want the rehab and the uncertainty that they might need something at 6 months of chronic reconstruction. If those, and after long discussion, if they want, then I'll do a tightrope fixation, otherwise default position is non-operative.
So let's be clear here. The type 3 indication for surgery is purely cosmetic. Purely cosmetic. It's not to do with function, really speaking.
I think there is a little issue here because when you see these patients who are type 3 to start with, and you might have done your stress views or everything, but their instability of the clavicle is not always superior to inferior.
All of them have it, but
and at 6 months, if I'm operating on somebody, I'm never operating on somebody for cosmesis. And in fact, they don't come for cosmesis. They come because they have got a functional problem. They feel their shoulder to be weaker in overhead position. They get this clicking from their AC joint, and when you stress them, they are moving front to back.
Yeah.
I think that is very important to recognize this anteroposterior instability rather than the inferior superior.
Kapil has raised a very, very important feature here that has been neglected for these years, that the coracoclavicle ligament is principally responsible for the vertical stability of the AC joint, and the acromioclavicle ligament is responsible for the anterior posterior displacement. Patients are unhappy from vertical displacement from the cosmetic point of view, but from the functional point of view is the anterior displacement that causes them lot of morbidity. Now here is a contradiction that the tightrope fails to address the anterior posterior instability.
I've modified my technique. I used to do the tightrope when I started doing it. I used to drill in one hole from top to bottom, and so it was one straight line. Now I do it as drill the clavicle and the coracoid in two different drills. So I start my drill in the clavicle much posteriorly, and then it sort of comes at an angle. But I think there is a distinction as well. We looked at our results, and we do all our tightropes open. And we have got better results than what Duncan Tennant has published or presented in his arthroscopic ones. And I think the key difference is that in an open, you reef the superior capsule, you repair the trapezio-deltoid fascia, and that acts as a secondary stabilizer. So yes, I agree that you're not, so you're reconstructing the conoid and the trapezoid with your tightrope, but I think repairing the accessory structures, because I always do a T-shaped longitudinal incision in the AC joint, or excise the disc and excise the disc in the clavicle, then I double breast this fascia on top. So I think that bringing up forward, and I've noticed that since that time I've been drilling sort of my drill hole in the clavicle bit posterior, I'm bringing the clavicle forward as I tighten the tightrope. But you're right, that is why tightrope has gone to the dog bone and the two segmenting and whatever. It remains a mystery and a conundrum, but I think the posterior instability is.
We'll come to that. Shekhar, your take on type 3 dislocations?
I operated few cases a year back, and it took them almost 2 to 3 months to gain that movement, and they would have gained that movement much earlier if I treated.
Non-treat, absolutely.
So I will never
Sure.
operate any patient for type 3, whether young or old.
You never operate.
For type 3.
Okay.
Type 3. So what about coming to your offer, what about the brachialgia? Some of these patients get this brachialgia as a decompensation, especially the high velocity traffic accidents and the alleged whiplashes, which are labeled as whiplashes with AC joint dislocations claims. They have these brachialgia coming in, brachial plexus, nervous pain coming down their arm.
That's interesting. How many people who come, and I know you don't believe in impingement, so but still some of us who still believe in impingement, the number of people we see with impingement and AC joint arthritis, a significant number of them have got brachialgia. They strive to see 5 cysts or sometimes in T1 as well. And the moment you do their surgery, now whether we're correcting their scapular posture, whatever we're doing, you do their surgery and immediate post-op, their brachialgia is gone.
I
So,
have seen this
and
many times.
is that brachialgia and the AC joint dislocation a symptom of the scapular position and the upper limb dysfunction rather than just the AC joint injury? But again, the AC joint dysfunction after a whiplash is also recognized.
Yeah.
This rotator cuff dysfunction is also
Yeah.
recognized.
But that's the disparate literature that gets published all across the world. We'll come to that. I'll allude to that when we talk on scapular. Ben Kibble has got a whole body of work on Bicalgia and AC joint instability. Now, how many here would believe that a biological reconstruction of the CC ligament would be better than putting a mechanical construct there on the AC ligament? Right. Whichever case.
No. Well,
Whichever case.
I'm sorry, but we had a very nice discussion about this with some guys from Netherlands in IOACON 2011, and what I learned and what I have been using since then is this: there is no logics in non-using biological grafts in chronic cases, because the biological potential for healing of the CC ligaments is about 8 weeks, 12 weeks. So in acute cases, I never use grafts once I am operated. But in chronic, I always use.
Sure. Sergio, let me pin you there. Let me compare this to how ACLs were treated 40, 50 years back when they tried to do acute repairs.
Yeah.
Now, when a ligament tears, it first undergoes a plastic deformation, lengthening, and then finally it gives and then tears.
Yeah.
So there's a gap between them. You're hoping that it'll heal up. It may not heal up in some of the patients at least. And if it heals up, it's going to be healing in a lengthened, inappropriate position, isn't it? So that's when the ACLs started failing, and they realized there's absolutely no role for primary ACL repair, and that's when they went on to reconstruction. So that's our argument, that why don't we do a biological hamstring graft for every AC joint dislocation that needs fixation?
Well, the thing is that still in acute cases, I mean type 5s basically, I reconstruct, but I believe in soft tissue healing. And in the end, what matters is that I'm going to have some kind of fibrotic tissue that will keep the clavicle in its position. And as a consequence, the body will not have problems to transfer load from the appendicular skeleton to the axial skeleton. And then the patient will not have pain, and everybody's happy.
Yeah, that load transfer is very important, because for, I think, millimeter to millimeter, the CC ligament is one of the strongest ligaments in the body.
Sure.
And that's why if you have a mechanical construct and the ligament fails to heal, then cyclic loading will cause the tightrope to fail. And that's why tightrope kept failing, and the inventors went on to say, oh, it's probably a design of the top button, so they changed it to the dog bone, and then they came up with the graft rope, which involves a synthetic tube with the graft inside. So why not do the graft by itself? So that's just to put the cat amongst the pigeon.
Is that we definitely don't have these devices in public system in Brazil. So I only do AC joint with 4 number 5 AT bones looping around
each other.
The coracoid, and it works fine. But in chronic cases, the 4 ones plus semi-T.
Semi-T. Offer?
I think it's a very, very important point that you raised, and for the older guys in the audience like me, I remember taking a lot of the Dacron tapes that we used to use many years ago, and they used to cheese cut the clavicle. And I am concerned about this tightrope thing and all these things that are mechanical, has no biology at all. And as we all know, there's obligatory rotational movement of the clavicle in the AC joint, and sometimes going to give either the bone or the device, unless you have something biological to
take over the load.
Yeah. And that's really important. That's just the point.
That's where the world is moving now. I think the recent literature is suggesting that we go into biological. But let's come to the last topic now. I have hugely controversial topic. Let's quickly take a straw poll amongst all of us here, including panel and myself, not myself. Displaced clavicle fractures. How, given a chance, is a nice, juicy, displaced 35-year-old guy, middle third clavicle, displaced, no neurovascular complications. How many of us would actually offer him surgery for fixation? 1, 2, 3, 4, 5. Okay. And the majority won't. Okay. So, Kapil, justify.
Can I get the mic?
Please.
I'll take a straw poll of 35-year-olds sitting here. We've got a displaced clavicle fracture, which is displaced by more than 1.5 centimeters in overlap. How many of them would want their fixed?
None.
None? That's interesting, because I would like mine fixed.
Yeah.
I'm not 35.
At 55 years old,
No, if you're looking at heart size, you're 27-year-old heart size.
And ticking.
So why would I fix a displaced?
Yeah.
Once you've done in your career 2 clavicle osteotomies with patients with severe rotator cuff dysfunction and shoulder girdle pain, falling clavicles that were shortened, and this is about 7 years after the initial injury, and 6 weeks after the osteotomy, the pain's gone. You get convinced that there is an evidence to do that. But then, if we believe in literature and we believe in level 1 evidence, then the work by Mike McKee from Canadian trauma group, we should either we believe in literature or we don't. If we believe in evidence, then there is definite evidence in that paper that on a general scale, if you do displaced clavicle fractures in the young adults, you will run into lesser problems than as compared to the conservative treatment. So hence, but the operative word is displaced.
Yes, displaced mid-shaft fractures. But the literature also says that the incidence of complications of fixing clavicles is very, very high.
Not in the Canadian study.
Well, the Canadian study very nicely did not mention this, but the American study and the study from Nottingham, Queens, have said that huge incidence of clavicle complications with fixations, and the complications rise from implant failure, implant breakages, infections, brachial plexus injuries. Now, when that happens, then that's even a no. Coming from Queens, I wouldn't say that. You wouldn't say that to Queen's Medical Center, Nottingham, of your poor surgery. I wouldn't want to do that. You're trying to build a line there. But on the whole, I think there has been too much hype. There's been a lot of pressure on. Vivek, what would your take be on clavicle fracture? Across the board, clavicle fracture?
I think in young individuals, Ashish and I would always would not have definitely that I will not operate. I'll also take his occupation demand into consideration. But given a choice, I would not operate. Unless until there's a floating shoulder, same extremity.
No, we're not going to that. So no, let's not contrive indications. Clavicle fracture with neurovascular injury, clavicle fracture, isolated, standard, because these are dime a dozen in our clinics. And so there are no formulate guidelines. Sergio, what do you do in Brazil?
Well, I don't want to...
You first cause a clavicle fracture and then fix it?
This is my lecture for tomorrow, clavicle fractures, but, well, I'm going to say it again tomorrow, but I deal a lot with this. I have many cases, and I am as conservative as I can when I'm talking about mid-shaft clavicular fractures in adults. How many nerve pulses I have had in 11 years? 0. How many, well, basically no complications.
Implant failures?
Me? No.
Oh.
And I fully agree with my friend here when he says that this is poor surgery. I fully agree, but what I want to do, I'm never afraid of operating clavicles. And I have a nice experience even with mid-shaft and distal clavicle non-unions. I'm going to show this tomorrow. But the thing is that even in a fresh case, I want to do something that in my mind I am doing the surgery because there's a need. So there are some friends of mine, I'm going to show this study tomorrow, that made a very good study, December 2012, published it in the Cochrane, about what is the best way to treat mid-shaft clavicles displaced in the adults. And the conclusion, it was that we cannot say nothing. Until this moment with multi-mega randomized studies. So, and what I tell my residents, while we have these very serious papers in literature, we have a lot of patients waiting for a decision. Yeah. So there are some ways to think, but this is gonna.
So what's the dysfunction with treating a clavicle conservatively?
What?
What's the dysfunction of treating clavicle fractures conservatively?
has two issues, displacement and shortening. So displacement, the thing is, once the clavicle heals, I'm not worried, and we have to understand that radiographical displacement doesn't mean a cosmetic problem. Yeah? So this is one thing. And the other thing is, how much shortening can you accept? Literature says 1.5, 2.0, but 1.5 is the same for a small woman and a tall man. No. So you have to be reasonable, you have to see the other side, and you have to understand who is the patient. A young sportsman has much more demand than a 72-year-old woman that stays at house. Yeah, so you have to understand the personality of the fracture. But shortening, I don't accept more than 1.5 and displacement. As long as I am seeing that the fracture is healing, I don't care.
So, Offer, you come from the rugby playing area. There are a lot of rugby players who have fractured clavicles and still playing rugby and efficient rugby at the top league. Do they have dysfunction?
Some of them will have this dysfunction. Again, I became more aggressive with the clavicle fractures because I get to see the non-unions and the pseudoarthrosis and the dysfunction later on. And I think, again, as Kapil said, it's much easier to fix them straight away.
Sure, it is easy. It's good for the surgeon's health.
Sure. Yeah, and you know, that's fine.
So there's a nice Australian paper amongst the rugby players who played with, it's in the sports journal, it's done by the physiotherapists, published them, and they went back to participate within 8 weeks of the fracture to the top level without affecting their performance at all.
Yeah, but if you think about the jockeys in the old days, they used to create a fracture in the mid-shaft of the clavicle, so if they fall, they don't fracture or dislocate anything. So they're the pseudoarthrosis, the mid-shaft.
Now we have one more indication for handling clavicle fractures in patients. I think we've run out of time. I think we should conclude this session. But Sergio, we are taking this to note down that in case you have a clavicle fracture, then one of the panel is more than keen to operate it for you.
But if I had a fracture, what would I do? With my one, you mean I'm mid-shaft. If I had until 1.5 centimeters of shortening, I would accept. And well, this is what I'm going to say tomorrow, that when you have in between the two major fragments, some bridge fragments, 1 or 2 or even 3, this is a huge invitation for healing. And once you don't have it, this is a huge invitation for non-union. So once you have a displacement, but once you have some fragments in between them, you bet that much.
No, Sergio, mid-clavicle fracture,
in me,
2 centimeter displaced in Sergio Rowan's case.
I will not operate.
You will not operate?
No.
Thank you. Okay, I think we've had Offer one parting word.
If you treat them conservatively, please treat them with a figure of 8.
Of course.
Because there was a paper somewhere that showed that the treatment of figure of 8 and sling is the same. Yeah, if you do a lousy figure of 8, it's the same. Please treat it with figure of 8.
The sling and the figure of 8 both are important. The sling takes away the weight of the arm. The figure of 8 braces them. That needs to be retightened every day. Don't demean the figure of 8 or the sling. Both need. You can't have only the figure of 8 because the arm is pulling the whole thing down all the time.
But you need to readjust the figure of 8.
Yeah, Nandan.
Be careful about the figure of 8 because I have reported a case report of
palsy.
DVT. Why does DVT happen to Britishers all the time? There are 2 reports of DVT after shoulder arthroscopy, both originate in south of England. Must be something they do.
I've got 2 with pulmonary embolism after a shoulder replacement.
But replacement is different. Shoulder arthroscopy and it's published in the journals.
It takes that longer to do a shoulder replacement as an arthroscopy. So
I've got 2 patients after ASD. They were 15 minutes on the tape.
See, these British patients, there must be a different ball game. It's the food you guys eat, I tell you. You must have more curry.
Absolutely.
it is the anti-inflammatory effect of the turmeric in the
Possible. There's more coming your way tonight. Next.
Thanks a lot,
everybody, and thanks a lot, and a special thanks to Ashish and the panel. I would now invite Debashish. Debashish is here? Yeah, Debashish and Offer, if you could please chair the next session. This is on instability, start to finish.
It's me? No, it's me. Debash, yeah.
Okay, so
Yeah, I'm just taking this off.
the first speaker is Dr. Oberoi. Critical questions you must answer before going to operating theater.
What we must prepare before taking our patients to theatre, before we are treating a patient with an unstable shoulder. A patient would come to your OPD and says, my shoulder slips out. All that slips out doesn't mean that patient is an instability case, because a lot of things do happen, like multiple loose bodies would give a sensation of slipping out of the shoulder. Patient may also says that my shoulder clicks and there are sounds, and these sounds can happen due to slap tears, torn edge of the tendon, biceps, a thickened bursa, or a scapulothoracic or an arthritic joint. So all those sounds and all those clicks does not mean instability. And when we see these patients which come to us with the instability, some of the issues which should answer due to examination and our investigation should be whether patient is having an overt instability, whether he is a case of a micro instability, or is a case of a multi-directional instability, or basically it's not at all an instability but just a feeling of instability. And slowly, step by step, if you start taking their history and examining, you would actually tend to solve all of these four issues. Now what is the problem? That's the basic thing which you should ask the patients, because patients may come with just frank dislocations or instability, but they may also come with pain and weakness. And pain and weakness are also signs of micro instability which might be happening. Diminished motion or a function is also an important feature which patient may come to us and also could say whether it is clicking or grinding. So in history you should be very, very clear whether patient shoulder is dislocating or not, or is it basically pain and weakness with which the patient is coming in our OPD. If there is a history of direct instability which patient says that his shoulder does dislocate, it's important for us to ask what is the degree of trauma. While the mild injury or a moderate injury is causing a shoulder to come out, what is the position of arm where the shoulder tends to dislocate? Is the patient able to relocate the shoulder back himself or not? And if he is carrying any X-ray documenting that whether it was really an unstable shoulder or a dislocated shoulder, or he just had a feeling of subluxation which happened and the shoulder reduced back. Apprehension is an important thing, and if patient says that after the injury he is avoiding that position of arm where the shoulder is dislocating or is feeling unstable, that's an important sign of an instability of the shoulder. Other joint laxity is also a predisposing factor which predispose a patient to dislocation. Number of dislocations and time period since the last dislocation happened also gives us an idea how bad this case would be once we start operating these cases. And if the shoulder tends to dislocate in sleep, probably we are dealing with a very difficult case to sort out. There are certain important clues in the history which can also tell us about glenoid bone loss, because that is one which is going to alter the method of treatment which we are going to take. So if the patient comes with a high energy mechanism of injury, he is probably having a glenoid bone loss. If the shoulder apprehension test is positive in mid-range of abduction and a lesser amount of external rotation, then conventionally what we would expect. And these patients which are more unstable in mid-range are one probably with more chances of a glenoid bone loss. As the patient starts to dislocate more and more and progressive ease of instability does happen, these are the patient again where they will expect bone losses. And if there is a prolonged history of instability and multiple episodes, all of these are indicators that probably the patient which we are managing would be one which would require a bone augmentation procedure rather than just an arthroscopic labrum repair. Some of these patients come to us after a surgery which has already been done. We must ask them whether this surgery helped in stopping the dislocations. Is he still having residual apprehension after the surgery? Does he get the range of movement back after this surgery? Or is there a late onset pain, which a lot of these patients come to us after surgery, either due to anchors, irritation causing arthritis in the shoulders, or stiffness which subsequently happens in these patients. So when we ask these patients their complaints about the treatment, we tend to get a preliminary idea whether we are dealing with a highly unstable shoulder or a moderate unstable shoulder, whether it is a macro instability or a micro instability, whether these are the patients probably which would require some kind of bone augmentation procedures or would just need some soft tissue procedures. And then go to step next, which is a physical exam. Probably it's important for us to examine, in addition to the glenohumeral joint, which is the joint of target, in addition rotator cuff, AC joint, but also see for generalized ligament laxity signs, which actually would give us an indication of something more which is happening in their shoulders. So inspecting these shoulders, front, side and back is important, especially seeing asymmetry, scars, wasting, swellings and deformities in these shoulders. Some of these patients would have a dynamic instability. They can actually demonstrate instability right in front of you, and these are patients which are voluntary instablers, which need to be, we should be cautious before operating these patients because they would be doing muscle patterning. Scapula is very important, and I think when you examine these patients with instability, it's important for also to examine the back, and probably scapular winging is something where dyskinetic scapula can lead to a lot of issues, especially micro instability. Sulcus sign is important sign, and if this is there, you understand that you are having a patient which is hyperlax and probably would require something more than just a labrum repair in these patients. Inspecting from back also gives us a clue of neurological issues which might be troubling a patient, which may be isolated infraspinatus weakness due to nerve palsy, and these are patients which are a different ball game than in conventional unstable shoulder. Scapular positioning and scapulothoracic rhythm are important. They tell us how the base of the scapula is sitting and how the glenohumeral kinematics are going to work. And a lot of patients which come with throwing sports often also have a glenohumeral internal rotation deficit, and this needs to be addressed before addressing to the instability per se. So all of these clinical examination, especially the rotation, the power, the strength, and internal rotation deficit and scapulothoracic rhythm become important prerequisite for us to mentally prepare ourselves before we go to theater to operate on these patients. Rotator cuff is an important entity which actually is a dynamic stabilizer of shoulder. Lot of patients who have unstable shoulders, especially older individuals, would also have a cuff integrity which would be doubtful and torn, and isolating each of these muscle groups and examining them pre-operatively is important test, because then our treatment would change. Probably just from a labrum tear, we might also need to do a cuff repair or just a cuff repair in these patients. Apprehension test is conventionally being done for most of us on an unstable shoulder, but it's important that you don't do apprehension test while patient is sitting. You actually make the patient lie down on the bed, at the edge of the bed, so that you actually stabilize the scapula before taking the arm in abduction and external rotation at 90 degrees or so. Pain alone does not indicate a positive. Basically, patients, you have to test and do a relocation test, in which case you actually press the humeral head down, and as you subsequently release the humeral head kicks back and patient tends to have pain. It's important for us to see for generalized ligament laxity signs. In addition, also do a drawer test where you can sit along with the patient and hold the proximal humerus, stabilize the scapula and move the humeral head anteriorly and posteriorly and see how much is the laxity anteriorly posteriorly. That's a drawer test which needs to be done. And a jerk test is one which gives us an indicator of posterior instability, which though uncommon is one which needs to be addressed preoperatively. So once you start clinically examining these patients and doing stepwise examination, you set up yourself mentally that now some radiological investigations are required before taking these patients to theater. Almost always we do a plain radiogram, try to do an AP view and an axillary view for unstable shoulders. It's important even to study an AP X-ray nicely, because some of these patients may often have a bony lesion here, which might be a bony bank cut or a bony glenoid tear, which needs to be addressed and it actually changes whole of your surgical plan. But important for us just not to depend upon an AP view once we are taking these patients for theatre. Special X-rays need to be addressed, especially an apical oblique and a West Point view. Probably these X-rays are important because they help us in addressing the bony loss. And if you look into these X-rays, you can actually identify a bony loss in the anterior part of the glenoid, which actually changes the treatment protocols which you might be following. Sometimes we also go in for a 3D scans, and reconstructed 3D CT scans actually help us in identifying the glenoid bone losses, and that's how a digital subtraction of a humeral head gives an image of a glenoid. Some of the acute losses would have a bony fragment which is separate but still intact, but then chronic losses would have a glenoid bone loss. It's important for us to identify patients which would require a 3D CT scans. And for me, I don't subject all the patients to a 3D CT scan except for such a certain indications, like the patient might have a multiple dislocations where I understand there would be a bone loss. The patient who has a bilateral shoulder dislocations, especially a dislocation on the non-dominant side, I would always ask for a 3D CT scan. A patient who dislocates after trivial trauma of the initial episode or a little provocation also needs a 3D CT. MRI or a X-ray which shows a glenoid bone loss again need a 3D CT scan to quantify the glenoid bone loss. Patients which have a history of instability in mid-range are one which strongly need a 3D CT, and whenever patient has been operated by some kind of stabilization procedures, I understand probably that surgeon would have overlooked a bone loss, and I would go ahead and do a 3D CT to quantify the bone loss in these patients so as to plan for my surgery. Understanding very well there are 2 or 3 different types of methods which we use to quantify a bone loss. One method is basically a surface area method where we actually try and draw a best fit circle here in the inferior 2/3 of the glenoid fossa and see how much is the bone fragment or a bone loss in such patients. Try to develop a ratio and percentage in those cases. Understanding very well in a chronic the bone loss would be too much and they would hardly find a bone fragment here. So this would be an inaccurate method of quantifying due to surface area. So we in our practice often do a glenoid rim distance methods, wherein again we draw a circle and see from the midpoint how much is the bone loss anteriorly, and with a formula try to evaluate it. Any bone loss more than 25%